A very good evening to one and all. My name is Manendra Singh Rathor. I am from the marketing team of Emcure Pharmaceuticals. On behalf of Emcure Pharmaceuticals, I take this opportunity to welcome one and all to this exciting session of known thrombosis workshop series in acute ischemic stroke. We at Emcure are highly privileged and honored to have some of the best faculty members in the field of neurology supporting us for this initiative. And without much ado, I will take this opportunity to introduce our eminent faculty members for today's session. First and foremost, welcome Dr. UK Mishra. Dr. UK Mishra needs no introduction. Sir is Director Neurosciences and Head of Neurology at Apollo Medic Super Specialty Hospital, Lucknow. Sir is the founding head and former HOD Neurology SGPGI Lucknow. Sir is also consultant at Vivekananda Polyclinic and Institute of Medical Sciences. Sir is Director, Executive Registrar, and Dean and in charge of research at SGPGI. Sir is trained in clinical neurophysiology in Italy, Sweden, USA as a World Health Organization fellow. Sir has made original contributions in the field of stroke, epilepsy, CNS infections, GBS, and neurotoxicology and others. Not only this, Sir has over 462 articles published in various reputed national and international journals. I take this opportunity to also welcome Dr. Jayanta Roy, who is our first moderator for today's session. Sir is Director Stroke Program and Senior Consultant, Department of Neurology, Institute of Neurosciences, Kolkata. Sir is Certified Neurosonologist, accredited by American Society of Neuroimaging 2005. Sir is a recipient of 2005 American Society of Neuroimaging William M. McKinney Award for the Best Manuscript based on clinical research in neurosonology. Sir has over 35 publications in various reputed national and international journals. Sir is also editor of various neurology books like the Clinician's Handbook in the Management of Stroke and a Clinician's Approach to Neurological Disorders. Welcome, Dr. Jayanta Roy, for today's session. Our second moderator for today is Dr. Pandurang Vatamar. Sir is Director and Senior Consultant, Intervention Neurologist and Epileptologist, Orion Criticase Super Specialty Hospital at Aurangabad. Sir has received several awards, including the Young Scientist Award under International Travel Scheme 2010 and 2011 from the Ministry of Science and Technology, Government of India. Sir has several publications in various reputed national and international journals. Sir has participated as speaker at multiple national and international conferences like the 29th International Epilepsy Conference in Rome and IANCon 2009 in Cochin. Welcome, Doctor, for today's session. I take the opportunity to introduce our third moderator for the day, Dr. Y. Muralidhar Reddy. Sir is Consultant Neurologist, Department of Neurology, Care Hospitals, Banjara Hills, Hyderabad. Sir has special areas of interest, which includes neuromuscular and neuroimmunological disorders, stroke and cerebrovascular disorders, vascular and neuromuscular ultrasound. Sir has several achievements, and these include Best Outgoing Student in MBBS. Sir has got 5 gold medals in MBBS and was university topper in second year MBBS. Sir is a recipient of Sam G.P. Moses Gold Medal in DNB General Medicine, December 2010. Sir also has the Best Paper Award in Stroke at IAN 2021. Sir has 20 publications in index journals as well. Welcome for the session today, sir. I also take the opportunity to introduce our first speaker for the day today, Dr. Madhupurna Paul. Doctor is Consultant Neurologist, Narayana Multi-Speciality Hospital, Calcutta. Doctor has areas of interest which include general neurology, autoimmune neurological disorders, multiple sclerosis, epilepsy, headache, Parkinson's disease, and other movement disorders, peripheral neuropathy, and stroke. Ma'am has over 10 publications in various reputed national and international journals. I also welcome Dr. Manoj Bharat, who is our second speaker for the day. Sir is consultant neurologist, Pradeep Neuro Hospital at Nirmal in Telangana. Sir has received several awards and accolades, which include first prize in the National Neurologic Quiz Arpan, organized at NIMHANS in 2019, first prize in the State Hematology Quiz, organized by the Hematology Society of India. Sir is also a recipient of Young Scholar Award. He was the topper for South India Zone. Sir has received the Bursary Award at the World Congress Neurology at Dubai in 2019. Apart from this, Sir has made several presentations in various conferences, which includes the American Academy of Neurology at Toronto, Canada in 2020, World Congress Neurology organized at Dubai in 2019, and the Indian Academy of Neurology, Hyderabad in 2019. Welcome on board, sir. This is our program agenda for today. And without much ado, I would like to hand it over to Dr. Professor UK Mishra to share the overview of the program and take this forward from here. Over to you, sir.
Thank you very much. Good evening. Am I audible?
Yes, sir, you're audible.
Yeah, okay. Thank you. So, distinguished panelists and presenters, it's a privilege for me to be associated with this program. And a long time we have been continuing this program with very good support with Dr. Roy and many other moderators who have been joining from time to time. But Dr. Roy has been there right from beginning. And what a pleasure it has been to learn together. No two cases are identical. You are thrombolizing day in and day out, but no two cases are identical. Every case is different, and that difference are the opportunity for learning. And whatever is beyond our expectation is the learning. So I think we have collected small and big points of thrombolysis throughout this journey. And this case presentation mode, it's not very important and not given great respect in academic circles. Everybody talks of how many cases and how many trials and how many such many reviews you have written. Nobody talks of cases, and the evaluators also don't give you great importance. The journals also look down the cases. They say they convert a case into a letter, but they don't realize that these cases are the cornerstone or the basis of all the learning. All the trials, all the systemic reviews converge to a case, and from the case only every further information comes. So I'm a believer of cases. Case discussion are the real learning opportunities, and the only journal which respects cases in a reasonable way is the postgraduate medical journal. Why? It was founded by William Osler. And so they carry his philosophy. And, if you write a small case, sometimes they give you more. And if you write for 700, they will ask you to write for 10,000, give you more opportunity to express. So I think, it's all right. Many journals may not give great importance to cases, but there are some which give it importance. And some clinicians definitely, those who are here, value cases very much. So I think this is a great opportunity to learn. And I consider it a great opportunity that, the people have worked hard way. They've gone to the stress and strain problems and follow up, and they present you in 20 minutes. So this is a great opportunity. And I'm very thankful to all the presenters. And only presentation without discussion, without questions, no good. And we could have no one better than Dr. Roy to raise questions and answer those questions. So thank you very much. And let's go with what Dr. Roy has to say, please.
Thank you, sir, for this very nice introduction and for those kind words. And I fully agree with you, the way we are having this journey together and learning every day from our colleagues and others. So I think we should start our cases now. And the first presenter will be Dr. Madhuparna. So Madhuparna, are you ready? Madhuparna, you are muted. You are muted. Unmute. Yeah. Okay, please start.
From where should I screen share this presentation?
Go to the down. There is a green button called share screen.
Mm-hmm.
Click there.
Yeah.
And your desktop will be visible, right?
I'm clicking, but the desktop is not visible.
Should be. I mean, do one thing. You open your PowerPoint.
Okay.
Keep your PowerPoint open, and then go to the share screen. Then it will straight away go to your PowerPoint. Once you click share screen,
Mm-hmm.
see.
Doctor, you shared the screen at the start of the meeting. Same way, you can just go to the bottom. There is a green button, share screen.
Yeah, I have seen it, but I don't understand. I have opened this PowerPoint.
Okay, you open the PowerPoint, that's fine. Then come back to the Zoom. And when you click the share screen button, what do you see on your screen?
So like in Zoom, I'm coming back to the Zoom, but it's not showing that previous one, the previous screen.
Now, once you click the share button, something pops up and you see something on your screen. There are, and among them, you might see your PowerPoint open, because this is already open in your desktop. Is that right?
You will see a new window pop up, doctor, once you click on share screen.
Actually, I'm exited from this meeting. How is it?
No, you are not. Otherwise, we could not hear you. You
No,
are not.
but it's not showing in my desktop.
I mean the Zoom.
Yeah.
Yeah, it must have been minimized. You will see a minimized screen somewhere down below with an arrow. Just click on the arrow, it will be maximized.
Yeah. So 1 minute. Yeah, now it's open.
That's right.
Visible, sir?
Yes,
Yes,
it is.
doctor.
It is. Just make it a full screen.
Mm-hmm.
Perfect. Please go ahead.
Good evening. So today I'll discuss about the role of intravenous thrombolysis in large vessel occlusion, and especially in the era of mechanical thrombectomy. It's not moving. It's not going to the second slide.
Doctor, just click on the screen. Just click on the screen and press the next arrow.
Okay.
Yeah.
So as we all know that stroke is the second leading cause of death and the first leading cause of disability worldwide. Around 65 to 85% of strokes are due to infarction caused by thrombosis of intracranial vessels. And IV thrombolysis with tissue plasminogen activator is the treatment of choice if the patient comes to us within the window period of 4.5 hours. But it has been seen that only 13 to 50% of the patients are having proper deperfusion after IVT for proximal large vessel occlusive stroke. And here comes the role of mechanical thrombectomy. For the last 2 decades, mechanical thrombectomy has been increasingly used for large vessel occlusion. So let's have a quick look about the large vessel occlusion. What are the large vessel occlusion? The large vessel occlusion means when the occlusion involves the intracranial ICA or M1, M2, M3 of MCA or A1, A2 and intracranial vertebral artery or P1, P2 of PCA or basilar artery. There are many pre-hospital scales to diagnose LVO, but let's have a quick look about the clinical symptoms which you commonly see in the emergency. For ICA or proximal MCA, there is contralateral hemiparesis, numbness, contralateral homonymous hemianopsia, ipsilateral gaze deviation, aphasia, or hemineglect. For vertebral artery, basilar artery occlusion, there is signs of posterior circulation, stroke like hemibody weakness, numbness, dizziness, nausea, vomiting, gait disturbances. And for PCA, the contralateral homonymous hemianopsia or quadrantopsia. So the patient who should be taken for mechanical thrombectomy with stent retriever, they should meet all the following criteria. That is, the pre-stroke MRS should be 0 to 1, causative occlusion should be in the ICA or M1 of MCA. Age should be more than equal to 18 years, NIHS score of more than equal to 6, aspects of more than equal to 6, and treatment can be initiated within 6 hours of symptom onset. With this knowledge and background, let's move to the cases. So our first case is about a 65-year-old hypertensive lady who came to the emergency department with sudden onset unresponsiveness. The ED doctors assessed her and noticed a gaze preference to the left. Her GCS was very low, and so we intubated the patient. The NIHS was 20. Stroke code was activated. Patient was subjected to immediate CT brain along with angiography and also MRI brain screening. So this is the CT angio of the patient where we can see occlusion of left ICA, and this was the MRI of the brain showing large left MCA territory infarct. So the onset of stroke was around 10:30 a.m. She presented to us at 11, and by the time 11:40 the imaging was done. Now, should we go for thrombolysis in this case, or directly should we take the patient to MT? So the decision was like imposed on us. The cath lab was occupied by the cardio people, and it means that we should immediately go for thrombolysis for this patient. So we proceed to IVT with Tenectase, and soon after IVT, we shifted the patient for MT and we took her to the cath lab. So in DSA, we saw that the ICA was recanalized, but the M1 part of MCA was still occluded. But when we took the second shoot and the catheter was also introduced as we were planning for endarterectomy, the second shoot we saw that the M1 was also get recanalized. So the 48 hours after her stroke, she was extubated. She remained aphasic, but had an excellent motor recovery. This we can see. The motor power improved in this patient, but she became aphasic. And the 3-month MRS was 2. So CT brain 48 hours after IVT was done, and we can see here the subcortical structures are well preserved even after such a large infarct. Now coming to the second patient, this is a 66-year-old lady who had no previous comorbidities, presented to us with sudden onset aphasia of 1.5 hour duration. On examination, we saw that the patient was aphasic with a gaze preference to left. She had right hemiparesis, NIHS was more than 10, and stroke code was activated, and we immediately shifted the patient to CT. CT showed the aspect score was around, Now we did CT angio, which revealed that left MCA occlusion, and here we can see the MCA occlusion, and the patient was shifted to emergency department where we thrombolized the patient with Tenectase. After that, she was taken to cath lab, and after DSA, we saw that there was spontaneous recanalization of left MCL. She had a complete recovery in 24 hours, and she was discharged on day 4, and her MRS was 3. Her MRS was in 3-month follow-up was 0. So in both the cases, we saw that the patients, these are patients eligible for MT, and despite of that, we went for IVT in both the patient, and both the patient had a good response. Now a brief discussion about the various guidelines for acute ischemic stroke. This is the guideline which was given by American Stroke Association and American Heart Association, where we can see that even if the patients are planned for mechanical thrombectomy, the patient should be given IV Altiplase before we take the patient for mechanical thrombectomy. This is ESO guideline for the same, and IV thrombolysis. We all know that the patient, if he or she is coming to us within 4.5 years, we should go for IV thrombolysis of the patient. Now, this is the recent guideline given by ESO, where we can see that for the stroke patient with anterior circulation LVO who are directly admitted to MT capable center within 4.5 hours of symptom onset, this patient should get the treatment with IVT even if we are planning for MT. And also for the patient who are in the centers where MT facility is not available, these patients are, if eligible and they are coming within the window period, they should also get the treatment with IVT before we ship the patient to the MT capable institutes. This review where the direct mechanical thrombectomy without IVT versus the bridging therapy, here we see that though there is no difference between the two groups, but still if we are planning for the patient, planning the patients for MT, we should give them IV Tenectase. And in this study, like SWIFT drift study, the preliminary results also showed that the direct mechanical thrombectomy alone failed to demonstrate non-inferiority to IVT plus thrombectomy, that is the bridging therapy. Now let's have a brief discussion whether to go for Altiplase or Tenectase in these patients who are planning for IVT. We know that Tenectase, it is the bioengineered form of TPA, and it is because of this change in the protein in the 3 sites of the Altiplase, it has a longer half-life, and hence we can give it in bolus compared to Altiplase, which is usually given in bolus followed by infusion. The ESO guideline recommends for patients with ischemic stroke less than 4.5 hours, whom we are planning for IVT and mechanical thrombectomy, we can go for Tenectase with this patient, though the quality of evidence is low, but the strength of recommendation is also weak. And in this study where IVT with Tenectase in patients with LVO, here we can see that 4 randomized trials where meta-analysis were done and 433 patients were there. And in this study, it is seen that acute ischemic stroke patient with LVO receiving IVT with Tenectase have significantly better recanalization and clinical outcome compared with patients receiving IVT alone. Sorry, IVT with Tenectase. And now this is the Indian study, 10-volt study. It also compared Tenectase with Altiplase. And in this study, though the study sample was very small, it was only 120 patients, and there was no median MRS score in 3 months. There was no difference in both the group, but the Tenectase appeared to be efficacious than Altiplase in the setting of our country like India, where we have low resources, and because of the low cost and ease of administration, Tenectase is efficacious than Altiplase. So the take-home message is IVT is definitely a must for eligible patients, even if we are planning MT, and Tenectase is better because of its low cost and ease of administration, and some studies showing the decanalization rate as comparable as Altiplase. So we have to remember that the direct MT versus bridging therapy, which was done at comprehensive stroke centers, where both the treatment options were available under one roof. But in our setting like India, IVT has a huge role to play, where shifting patient to center where MT is available requires time. So to conclude, that we know that as every patient, 30-minute delay in recanalization decreases the chance of good functional outcome by 8 to 14%. So let's not forget the mantra, time is brain, and let's conclude with the note that no patient should be denied of IVT, either Altiplase or Tenectase, if he or she comes to us within the golden hour of 4.5 hours, unless otherwise contraindicated. Thank you.
Thank you, Madhuparna. I think that was an excellent presentation. I must congratulate you for treating those two patients is exactly the way it should have been done. So very well treated, exactly the right way to treat them through bridging. And you have very clearly conveyed your message that bridging therapy, IV followed by mechanical thrombectomy, is still the preferred mode rather than only mechanical. Now you have also, explained them through the recent publications, including the latest guidelines, that this combination therapy is the preferred mode, and there are several reasons for that. And the world is still believe that IVT should not be denied to a patient unless there is a specific contraindications, because there are several advantages. We'll come back to that, but before that, let us see if there is any question waiting for us. Is there any question waiting?
Sir, as of now, there are no questions.
Okay. Murli, is there any comment from your side?
Yes, sir. I actually congratulate her for very well presented and for taking the right decisions for the patients. At our center at Care Hospital, Hyderabad, actually from the time the extend 1 year result results have come, we have always been giving Tenectase before mechanical thrombectomy. So whenever a patient of such mechanical thrombectomy candidate within 4.5 hours, we never did direct thrombectomy. We always gave Tenectase, and to our surprise, we have actually seen 3-4 patients, even when we take up to the lab, actually the vessel has completely opened up also. So many times it will happen, and we actually stopped giving Alteplase if we are planning for mechanical thrombectomy altogether. That is one thing, and also it is because it is ease of administration. It is just a quick bolus. It is very useful and very ease of administration with that. Actually, I have my friends also, who general medicine friends from who are in the peripheries, just nearby our hospitals or in the peripheries. They actually call me and send the scans what to do. They have easy Tenectase. I just give Tenectase, and it is like a drip and ship. It is very easy, and actually they ship the patients. So actually our center has made it a rule that actually whenever a patient is taken up for mechanical thrombectomy, give Tenectase. It is very easy, push and ship the patient. So very well managed cases.
Great, thank you. Dr. Watamar?
Good evening, everyone. Both the cases were very nice cases, and it not only the one thing that IVT should not be denied to any patient who is in window period, even if the candidate is for mechanical thrombectomy. That is the right point you have, the right thing which you have wanted clearly. One thing I would like to highlight is like Tenectase. Our center was involved in one of the initial trial which was conducted at multi-center in India, and since then, around 5-6 years back, since then I have stopped using Alteplase. Yes, we use completely Tenectase, and the recanalization rate of Tenectase is significantly better with Alteplase. Even with large vessel occlusion, we see, I am an interventional neurologist as well. I do from acute stroke thrombectomy quite often, and we often see such cases with especially M1 occlusion. IC occlusion recanalization is not that good, but M1 and beyond that, the recanalization rate with IVT in window period is quite good. So both cases were very good. I congratulate doctor and best wishes.
Thank you. Sir, Professor Mishra, sir, any comments, sir?
Sir is muted.
Sir, you're muted.
Yeah, and thank you. I mean, both the cases were very nicely presented, and they came in the right time and right decisions were taken. But, there are cases, there are positions that, when a patient comes, people tend to go for thrombectomy. And, the intervention radiologists have a tendency in some hospitals. It depends, sometimes patients are referred to them directly, and sometimes I have seen that people want to vouch for direct thrombectomy. The evidence doesn't support that, but there are always such issues coming up, and we should try to convey the guidelines and the information and try to persuade. But I think in both the cases, the message is very clearly given. Thank you very much. And we can go to the next case.
Thank you, sir.
Thank you.
Thank you so much.
I have a comment, sir, to make.
Tell me.
Yes, sir. Actually, the trial, as per the trial, it is M1 and also IC occlusion. So, I mean, I just want to know how Tenectase actually worked in posterior circulation strokes too. I mean to say, in compared to the anterior circulation strokes, there is yet, yes, evidence is there, but posterior circulation strokes, I just want to know from the other faculty too.
I think we still do not have much information on that. I mean, those 6 important trials which have been RCTs are now available answering this question, that is, which one is better compared to bridging versus direct mechanical. And 4 trials we have, they are already published, and 2 trials, they are completed. So data is available, but not yet published. That is I think the DEV trial and another one. So there is only one which looked at the posterior circulation, but all of them used alteplase. None of them actually used tenectase. So if we try to look at the answer in these 6 trials, including your direct MT or Mr. Clean no IV or DEV trial, or those 6 trials I'm talking about. So we do not have that answer, but I think we can probably Tempo 2 trial can give us some data on these, maybe sometimes next year. And but in my opinion, in everybody's opinion, I think we have started liking tenectase because of those obvious reasons. And extend IATNK has clearly shown that there is some benefit, and we are also experiencing the same. So I advocate tenectase in this scenario, and I'm also a strong advocate of this bridging therapy because of many reasons already discussed. But once you open up the artery and there are smaller clots going M2, M3 or smaller branches, where your TPA on board is the best thing to open them, rather than only mechanical. And I mean, my intervention friends, they all say that even if you see there is a clear-cut case of M1 occlusion, and everybody thinks it's a piece of cake, but having a difficult access, having a tortuous anatomy, there are so many factors which delays your the thrombectomy process. So having TPA on board is always an advantage, rather than just relying on mechanical thrombectomy and then having another result. So I think Dr. Watamar, who is also an interventionist.
I also feel that bridging is the way we should go ahead. There are a few incidences where we had to face a problem like femoral hematoma and reperfusion bleed. But I don't feel that direct mechanical thrombectomy and going via bridge, initially giving IVT, that does increase the risk of bleed. I don't think so. So it is we should give IVT for eligible patient within window period. And if there is a large vessel occlusion on imaging, then after giving IVT, the patient should be moved to cath lab.
Yes, and there was my last comment. There was a paper published in Neurosurgery sometimes last year who looked at this issue of if we stent during a mechanical thrombectomy of in situ stenosis. It happens in rare cases. What is the risk of loading them with antiplatelet within first 24 hours of giving IVT? Whether there is an increased risk of bleed.
Yeah.
That was the apprehension. But they looked at this data and they found that there is not much of higher incidence of bleed in those cases.
So even if stenosis is there, many a times we avoid to put a stent in acute setting. So once we do the thrombectomy, if once the vessel is open enough, and if underlying stenosis is there, we prefer to get the patient stabilized. After 2 weeks or 3 weeks, we go for intracranial angioplasty.
Maybe an angioplasty might help at that scenario.
Yeah.
To make access and then come out and later on go back and do it.
Yes.
I think that makes sense. So thank you, Madhuparna, for your excellent presentations. So I think we should proceed to the next case. And Mr. Doctor, who is the next presenter?
It's Dr. Manoj Bharat.
Oh, Dr. Manoj, are you here?
Yeah, I'm here, sir.
Yeah.
Sir, shall I go ahead with the presentation?
Please go ahead.
Yeah. Good evening, everybody. This is Dr. Manoj Bharat. I'm a consultant neurologist based in Remark, Telangana. And today I want to talk about being flexible with the exclusion criteria for thrombolysis in acute ischemic stroke with whatever little personal experience that I have. So when I was first asked to talk on this platform, my initial plans were different. I thought of presenting a few cases where improvement with tenectase was drastic, showing some videos of patients improving in minutes post thrombolysis. But then later I thought of touching on the gray, relatively untouched areas so that a debate would be sparked and it encourages mutual learning. So before I proceed any further, I want to make certain declarations. One is the nearest MRI center to my hospital is 80 kilometers away. I work at a periphery. And my center caters to a not so affordable population. I'm the sole doctor at my center. I started my practice in March 2021. The first thrombolysis that I've done is on August 30, 2021. So the first 6 months went off with no thrombolysis done. And the next 3 months I've done 3 thrombolysis. And the last 4 months I could actually do 11 cases of thrombolysis. So I tried to improve myself on the thrombolysis front. And now moving on to my cases. So this is my first patient who happens to be a 40-year-old male. He's an auto driver by occupation. He's a non-diabetic, non-hypertensive. He's an alcoholic and a non-smoker. He presented with history of sudden onset of right hemiplegia of 1.5 hours duration. His NIH at admission is 15. His past history was significant in that he had bleeding hemorrhoids for 6 months and he last bled around 2 weeks back. His CT scan showed all those classical early CT signs of acute ischemic stroke. He had this obscure lentiform nucleus sign. He had this disappearing basal ganglia sign where the margins between the basal ganglia are blurred. And he had the insular ribbon sign and the sulci are effaced. And even the sylvian fissure on the other side was less prominent because of edema. So he seems to be an ideal candidate for thrombolysis. But then AHA 2018 guidelines comes with stop boards and warnings. So the recent episode of hematochezia that he had because of bleeding hemorrhoids qualifies as a gastrointestinal hemorrhage in the previous 21 days, making the patient not eligible to thrombolysis according to the exclusion criteria of AHA 2018. So coming to the next patient, this is the story of a 58-year-old woman who is a diabetic on oral hypoglycemic agents. She had an ischemic stroke with mild light hemiparesis 1 month back. She fully recovered over 5 to 6 days. And now she has come with left hemiplegia of 3 hours duration. The weakness this time is severe. The power is 0/5 in the left upper limb, 1/5 in the left lower limb. And the NIH score at admission is 18. So her CT was showing a small focus of subacute chronic infarct on this side. But then on the other side, there is no evidence of any new infarct or hemorrhage. So for me to thrombolyze this patient, I again had problems because this patient had ischemic stroke in less than 3 months, which makes her not eligible for thrombolysis according to the recent criteria. Also, since she has presented 3 hours after the symptom duration, and her having a previous ischemic stroke and diabetes mellitus, this comes as an additional warning sign. And this is the patient who I have seen recently. He happens to be a 46-year-old male. He has right hemiparesis of 1 hour duration. The NIH at admission is 11, but then his past history was significant in that he had left hemiparesis 1.5 years back, and he fully recovered in about 1 month after he got admitted to a hospital. So his CT that I initially got done was showing something which I was thinking like a chronic lacunar infarct in the putaminal region. But then on asking the patient's son, he said the patient is told that previously he had a bleed in the brain and it's not a clot in the brain. So I got the previous scan retrieved, which was showing a hemorrhage in the right putaminal region. So this actually happens to be a resolved bleed in the putaminal area. So for me to thrombolyze this patient, again, the criteria comes and says that you cannot thrombolyze because the previous intracranial hemorrhage that this patient had, though it was 1.5 years before, qualifies as an exclusion criteria. And according to the guidelines, we cannot thrombolyze this patient. So how do we proceed? So all the 3 patients either have the contraindications or the warning signs against thrombolysis as per the latest guidelines. But at the same time, we all know that all these patients can also potentially benefit from thrombolysis. So on our way to thrombolysis, there are too many stopboards which are given by the guidelines. But the question that needs to be answered is whether all of these stopboards should really make a stop. So this takes us to the next question: are exclusion criteria for thrombolysis really so absolute? So there is mounting research, as we all know, on the benefits of thrombolysis in these patients with apparent contraindications. Thrombolysis in these specific subsets of people may not be as harmful as it is previously thought. And there is so much literature on the benefits of thrombolysis and no significantly increased risk in patients who would otherwise be excluded based on the guidelines. So I just wanted to share just a few of them. So this one is an article which is published in European Stroke Journal in 2019. And this article talks on thrombolytic therapy in older adults with stroke with history of gastrointestinal malignancy or recent bleeding. And this says that there is no increased risk of in-hospital mortality or bleeding in RTPA-treated patients who have been already diagnosed with the GI malignancy or had a recent gastrointestinal bleeding. And this article talks on why should not intravenous thrombolysis be given in patients with recurrent stroke in the last 3 months. And this says that there are several recent studies which studied that intravenous thrombolysis may be actually beneficial in this patient population. And they also found that IV thrombolysis in these patients is not as hazardous as is previously thought to be. So this third article talks on whether we should exclude acute stroke patients with previous intracranial hemorrhage from receiving intravenous thrombolysis. And the results of the study say that previous intracranial hemorrhage may neither increase the risk of symptomatic hemorrhagic transformation nor alter the major clinical outcomes in acute stroke receiving IV recombinant tissue plasminogen activator. So this study suggests to reconsider a prior history of intracerebral hemorrhage as an exclusion criterion for IV thrombolysis in acute ischemic stroke. So these are the various concepts that are hovering around regarding stroke and thrombolysis in patients with apparent contraindications or exclusion criteria. But then there is this criteria which try to unify all these concepts and tried to bring in a one single unifying criteria, and this is called the SMART criteria. SMART criteria stands for Simplified Management of Acute Stroke Using Reverse Treatment. This is not a new criteria. This has been there for the past 6 to 7 years. It's been first published in 2016. And according to this criteria, there is only one absolute exclusion criteria for stroke, that is presence of hemorrhage on a CT scan, which is felt to be causing the patient's symptoms. So even a resolving hemorrhage, which has caused a previous stroke, doesn't come under the absolute exclusion criteria according to the SMART criteria. And this study, the multi-SMART study, has concluded that the generalized application of SMART criteria is safe and effective, and widespread application of this criteria could substantially increase the population who might actually qualify for treatment with thrombolysis. So the premise of these SMART guidelines is the fact that IV RTPA treatment criteria are a bit restrictive, and the data which comes from clinical trials may not actually be exactly extrapolated to the clinical practice. And most of these RTPA exclusion criteria are not evidence-based. If you can see, it's not evidence-based. It's most of the times it's expert opinion or having low quality evidence. So this SMART criteria helps us rethink of the exclusion criteria and streamline management in patients with acute ischemic stroke. So what did I do with those 3 patients that I have previously talked about? I actually went ahead, thrombolyzed all these 3 patients, and the patient's clinical course is what I'm going to explain now. The first patient was that young patient who came with a recent GI bleed. Why did I go ahead with thrombolysis? The reason I went ahead with thrombolysis is because the hematochezia that the patient had was not very severe. He was an young patient. He had a severe stroke, and the benefits of giving tenectase actually outweighed the risks. So tenectase is given at the standard doses. The door to needle time was 40 minutes. The onset of symptoms to needle time is 2 hours, 10 minutes. And the patient actually started walking within 10 minutes of giving tenectase. The NIH at admission was 15. At 24 hours, it was 3, and at discharge was 1. Patient is coming for regular follow-ups, and his modified ranking score at 3 months is 0. And this is the second patient, who is that lady with the recurrent ischemic stroke. And the reason why I went ahead and thrombolyzed the patient was that the previous stroke was very mild, and the CT showed only a very small infarct, and there are no other exclusion criteria. And I felt that the benefits of giving IV thrombolysis actually outweigh the risks. And tenectase again is given in standard doses, and the door to needle time was 45 minutes. Onset of symptoms to needle time was 3 hours and 45 minutes. And the patient is doing well at 3 months of follow-up. And the third patient is that patient with the past history of intracranial hemorrhage. And the reason why I went ahead is that the ICH is quite old. It is 1.5 years old, and there are no other contraindications or warning signs in this patient. And I felt that the benefits outweigh risks for this patient. And tenectase was again given to this patient at 15 mg IV stat. The door to needle time was 30 minutes. The onset of symptoms to needle time was 1 hour, 30 minutes. The NIHS at admission is 11, and at discharge was 0, and the patient is doing well. So these are some of the vials which I had the habit of writing the patient details on the vials which have really been so successful in thrombolyzing the patients. So among these 8 to 9 vials that I have used in the past few days, at least 3 patients started walking. They completely recovered within 15 to 20 minutes, and some patients have done well over the next few weeks. So concluding, I want to tell that I'm not trying to drive home the point that we should thrombolyze all patients despite contraindications. No, that is not my point. What I'm trying to tell is all these criteria, they keep on evolving. Many previous exclusion criteria, according to AHASA 2015, are actually removed according to the AHASA 2018 guidelines in the 2019 update. And many previous warning signs are also no longer warning signs at all. So patients outside the guidelines window can still benefit from thrombolysis without significantly increased risk. And let the guidelines guide, but not dictate us in our day-to-day clinical practice. And it's finally the neurologist's call, taken on a case-to-case basis, rather than strict adherence to the rules of the game, that matters in thrombolysis in stroke. Thank you.
Thank you, Manoj. We all enjoyed your smart presentation, and I think you have brought up a very fundamental question about these relative contraindications of thrombolysis and how a stroke specialist or a neurologist should deal with that in a real time, looking at the relative risk and the benefit, and the way you assess the patients, you assess the situations and treated the patients, giving them the benefit of this treatment is exactly the way it should have been done in the most rational way. So, sir, any comment, Mr. Sir?
Yeah, nice presentation, and enjoyed it. We must understand that when you plan a trial, your concern is to convince the ethics committee and the consumers that you are safe. Therefore, what we do, we build in all possible problems and try to say that we will take care of everything. And therefore, you see the inclusion criteria run into, inclusion and exclusion criteria especially run into a whole page or something. It's very lengthy and elaborate. And then when you have, and the patients you select in a trial are extremely clean, and you try to present as ideal case. But when we go into the practice situation, and not so clean. There are comorbidities, there are confounding variables which you all have to take. We must understand that when we have a trial data, that it is only to convince us regarding the efficacy and safety. But when we become a clinic, as a researcher, you try to be as stringent as possible. But when we go as a clinician, we have to take an individual decision based on cost benefit analysis. What are the risks and what we are investing and what are likely to get, and therefore these decisions have to be taken in that way. We have seen that the trials have been faithfully reproduced, but if you try to follow all the criteria, you will hardly get patients, very clean patients will be very few. Ideal is difficult to achieve. So I think we read the trial, we understand it, and then try to understand the spirit behind it, and we have to be safe. So I think I fully agree, because the distinction between, ischemics in a hypertensive, a acute, and a hemorrhage, the pathophysiology is more or less same. It's a chronic changes and a Bouchard aneurysm or a thrombosis and a acute. So, they are overlapping things and they're happening simultaneously in the same patient. And if we try to exclude, then hardly anything will be left. So I fully agree with this presentation, and I'm with you that we have to take individual decision based on cost benefit analysis, and the intention are to give the best benefit. Yes, we talk very proudly and nicely because the patients have done well. But you imagine that we give Tenectase and the bleeding persists and the bleeding exacerbates. Then you have to give transfusion and call for help, and then there will be a mess. Unfortunately, those cases, are seldom presented, and if you send as a case report, the editor will say, why did you do it? So that is the thing. But you are fortunate, you are very correct in your judgment. Your patients did well, and we appreciate it. But, the whole thing and the decision ultimately lies with the result of the patient. How does he fare? If he fares well, everything is good. If there is a problem, we have to face. So I hope you agree with me. I'm not trying to confuse it, but I'm trying to tell you how I feel about it. But the presentation was good. It was needed. Enjoyed it. Thank you.
Thank you.
Thank you, sir. Sir, it reminds me a small story during my fellowship time. Can I say that?
Yeah, sure.
Can I tell the story? It's very interesting.
Sure.
Yeah. So my boss from Calgary, where I was trained, Dr. Andrew Demchuk, he told me this story during my training period. He told that, look, if you want to thrombolize, there are 1,000 reasons. If you do not want to thrombolize, you can find out 1,000 reasons not to do it. So it's the attitude of the treating physicians what you want to do. And he narrated one of his experience during his fellowship time in Texas, Houston. He was on call, and a lady came with an acute stroke, an elderly lady with 4 sons. And this family was the largest law firm of Houston. So they were, scared about any lawsuit arising out of that patient. So they were looking at every bit of contraindications in the list to find out any reason not to thrombolize the lady, lest she bleeds. But unfortunately, there was no contraindications. So with bated breath, they thrombolized the lady. And fortunately, she did well. I mean, this was a story that if you want to do it, you can probably give the best of your judgment, having, giving the benefit to the patient as Manoj did. And I think he did the right thing. But this is exactly the art of practicing medicine. What you learn over the time, and evidence doesn't tell you everything. But yes, it gives you some idea, then the experience, and then your gut feeling. Everything you join together. So, Murli, any comments?
Yes, sir. As rightly told, actually, bottom line is we have to search for a reason to thrombolize rather than search for a reason not to thrombolize. What he did is very right, and I actually commend him for doing such things in a very remote place. With very little things. Thank you very much.
Dr. Vataman?
I would like to congratulate Dr. Manoj, not only for thrombolizing all these 3 patients, but also for a very nice and dynamic presentation. And the only thing is the last patient, my gut feeling, I would be scared to thrombolize such a patient with past history of bleed, although that bleed was not very large enough. But that is the only thing I would like to comment on. But all 3 cases were very nice, and right decision was taken.
Yes, and personally, if it was a lobar bleed, I would have been a little hesitant to do that.
Okay.
But based on a CT, you cannot really assess whether there is an amyloid angiopathy or microbleeds are there in the lobar locations. On CT, based on CT, you cannot do that. But in a deep ganglionic site where there is a lacune or a bleed or even a microbleed in the deep ganglionic sites, I'm not really that concerned.
Okay.
But lobar location, a past history of big lobar bleed, elderly patients, I am little skeptic. But rest of the cases, old bleed, remote bleed, past subarachnoid, secured, subdural, I don't think we have any problem. So is there any question, Mr. Rathore?
Sir, there are no questions there as of now. We have almost 150 doctors who have logged in for the event. There are no questions though.
Okay, then I request Professor Mishra sir to give the concluding remark.
How can you conclude such a lively subject? Every presentation raises questions, and that questions linger in our mind and influence our decisions. Maybe whatever we have seen today will be in our subconscious, and when we see our next patient, all these things will come in our mind. So it has been a lovely evening, and we enjoyed both the presentations, and very good discussion, and things were brought out. And ultimately, what matters is that the patient should benefit. Patient should have no complication. He should be happy, and he should recover well. If that is there, all your decisions are good. And we pray that we take right decisions in the right time, and patients benefit. Thank you. It has been a lovely evening. I hope you'll all agree with me.
Thank you, sir. And before we hang up, just a very quick comment about Madhuparna's case. I forgot to tell that. Madhuparna, the patient you treated, when you showed the next day CT scan, and there was a large hypodensity of that lady, elderly lady, you might see a reperfusion edema in those kind of cases. So what you see as the hypodensity next day may not be the infarcted part. Those patients, if you do a repeat scan after, say, few weeks or months, you might see the whole thing shrinks. So a patient who early recanalized may have a reperfusion edema. That's why the motor recovery was quite good. So hypodensity might include the reperfusion edema part as well. Thank you.
Excuse me, sir. May I intervene, sir?
Yeah.
Yeah. Sir, I had two patients who initially got recanalized, improved so well, walked the first day, And then there was this early neurological deterioration post recanalization, probably. So 2 patients, and there was no evidence of any bleed. CT was not showing any worsening. The metabolic parameters were all good. So how do you explain that, sir?
Reocclusion? Were the reoccluded? Did you re-image them with vascular imaging?
Yes, sir. I re-imaged them. There was no increased infarct size, no edema or anything like that. And I did not have a CT angio back then at my center. So
well, I do not know. Did you do an MRI and see whether that was the whole thing is a restricted diffusion with the low ADC?
No.
Okay,
No, sir. Patients no.
This differentiation, I mean, it's arbitrary. This hypodensity, what we see in the next day CT in early decanalized patients, what I'm talking about is reperfusion edema. This definition is arbitrary. I mean, we cannot really differentiate, but patients with a large hypodensity in the hemisphere, with a relatively well-preserved clinical scenario, then we presume that this area is not probably infarcted. And this actually, it happens that they improve very quickly and significantly. But in your case, I really do not know. Without MR imaging, very difficult to say whether they had really infarcted later on or something like that. So an MRI might help to give you better clarifications.
Or one explanation could be actually when you thrombolize, the clot will actually dislodge to the peripheries also. So initially there may have been some improvement, and later the clot must have lodged in the peripheral vessel, and maybe that areas may have got infarcted. So that's why imaging and vascular imaging is very important.
That's right. And another point could be that though it has moved to say distal M2 or somewhere there, and the area is holding on with collaterals, which might have failed later. So initial improvement and then the collateral failure and the worsening that might happen, which you might not see with a repeat vascular imaging going up to the level of M3. This is one possible cause. Okay, so I think Mr. Rathore, we can probably.
Thank you so much, sir. I think it's been a great evening discussing the 2 cases. As I mentioned, more than 150 doctors have logged in for the event today. So I first and foremost take this opportunity to thank our guest speakers, both of Dr. Manoj Bharat and Dr. Madhupurna Paul. Thank you so much for sharing your cases with us and discussing them on this platform. I also take the opportunity to thank our guest moderators for today, Dr. Vatamar and Dr. Muralidhar Reddy, for taking time out from their busy schedules to be part of this wonderful evening on this platform. And last but not the least, cannot thank you more enough, Dr. Jayanta Roy, for being such a regular on this platform. Thank you so much. And thank you for moderating this session so well each time, every time. And last but not the least, thank you so much to Dr. and Professor UK Mishra for his constant guidance and mentoring to make this platform come alive every time. And with this, I also thank the audience who have logged in to be part of this program. Thank you so much. It was a great evening. Good evening and good night.
Thank you all. Thank you.
Thank you very much.
Thank you, sir.
Thank you. Good night.